Welcome to the update on the palliative care in the home care map updates. So this care map here is to be updated to the Shared Health website for August 1st. There hasn't been a drastic change in the care map itself, but there have been some changes in regards to medications and routes of administration. So to start things off, the only time we can access this care map here and use it, because there are some differences between our regular care and what we can do for our palliative care patients. The first thing is, turn the camera on. The first thing is that in order to access this care map here, the patient has to be registered within the IRHA Palliative Care Program. So it doesn't really matter where we are in the region, as long as they're registered within the IRHA, we can access care map. If they're from another palliative care program, such as WRHA or Prairie Mountain, we can't access the care for this care map. So to determine if our patient is registered with the palliative care program within the RHA, the patients should have documentation. They should also be given an SPP registration number. So ideally, when 911 is called for us to attend these patients, the people that are phoning or the caregivers that are phoning should have that registration number available. So their registration number, they have a decal that should be on their fridge that gives them that number. So, and the instructions on what to do if they need to call in an emergency. So as you can see here, the decal on the special patient decal there, the larger one, that should be what's on their fridge. So that way they have some kind of direction, because obviously in a crisis, people don't tend to think straight. So they need something to look at to give them an idea of what to do. There's also a patient wallet card, which is the smaller pictures there, so the front and the back, and that'll have their special patient registration number as well. So if you have a patient that you're not sure where their number is and you're out in the world and they're not in their home, you can look for that number on there as well. So one thing that's come up, we did a palliative care visit, myself, Lori, and Tammy Lee, our palliative care nurse. We went and visited all the stations within the region, and a common factor that came up quite a bit was that patients were missing documentation. And one of them was these decals, all the expected documentation fine for a patient on the palliative care program. So the problem is that when patients are just put into the program, you may be called the next day. So their paperwork may not be 100% put in place. They may not have these decals on their fridge, but they should have a SPP number. So at least ask them for that. And then that way we know they're in the program and we can access this care map. So reasons we can't use this care map, if the patient condition is due to an unexpected cause, such as an accident, suicide, attempt, or assault. So if the reason we're being called has nothing to do with their palliative care issues, like they fell off a ladder, tripped on a step, things like that, need a lift assist, we can't really access this care map. It's only if it's regards to their palliative care problem. If the patient's current goals of care include resuscitative measures, we can't really access this care map either, because when we talk about like end of life care and shortness of breath and giving opiates for shortness of breath, that might not work well with a DNR, without a DNR, because obviously if it slows the breathing down and ends up exacerbating whatever their end of life care is, they may not come back from that. So if they don't have an active DNR, we can't really use that medication. So the other thing there is, for the purposes of this care map only, true allergy to a medication is the only absolute contraindication to its administration. So for many of our medications, especially pain meds, if the patient's hypotensive and things like that, we can't give a medication. So with this care map, this is the exception. So of course, a lot of these patients are going to be pretty sick. They're going to be hypotensive to start with. We don't want to withhold pain control from these patients at end of life because they have low blood pressure. So we can disregard that for these patients. So for scope of practice here, so like all care maps that we have, if it says PCP, then PCP and up can access this. If it says ICP, ICP and up can only access this. And a lot of the medications we have on here are for PCP, ICP. For technicians within our region, if you're accessing this care map, you may not be able to access the use of the medications, but everybody's taken the training for the most part in this region now. And there's still the psychological assistance, just moving the patient, talking to the caregivers, things like that. You can still access all those soft skills. Just because you can't give meds doesn't mean that you're not going to be beneficial to these patients when you're on these calls here. So keep that in mind. A lot of this is supportive. not only for the patient, but also for the family. So sometimes we're just there to talk, get them through their crisis. We may not have to do anything with needles or meds or anything. It's just more so supportive for the family and for the patient, just to make them more comfortable and put them at ease. So the first thing we're going to do when we get on these calls, we're not going to treat it like we would a normal emergency, going in, putting people on monitors, doing vitals right away. What we'd probably want to do would be a better approach. We go a little bit softer approach, ask what's going on, why did they need us, and review the goals of care with the patient and caregivers. So we want to look at a patient's healthcare directive or advanced care plan to have the discussion of what can we do for this patient. So for example, if you come in, they say, oh, grandpa's having trouble breathing. And you're like, okay, what are his goals of care? Because obviously someone at end of life, we're going to treat very differently than say like a 12-year-old child having shortness of breath. So we need to have that idea of what kind of care they want. So with that, we want to keep in mind, we want to know who's in charge, who can actually make certain decisions for our patient, and we'd want their documentation. Like I said before, if they've just been registered in the palliative care program, they may not have other documentation in place that has been discussed with the palliative care program. Things take time. There's only a certain amount of nurses for a lot of patients in a very large region, so everything may not be put into place. So one of the pieces of paperwork that you should have there, though, this could be either in the ERIC package that the patients have on their fridge, or it could be in their actual physical paperwork binder. So they should have a folder in an envelope within the house. We've been asking people to leave it on top of the fridge, and just again, feedback from a lot of our medics is that's not where they are. We have patients hiding them. We have patients just putting them safely in a locked cupboard so people don't get into their stuff, things like that. So we want to try and get our documentation as soon as we can. But the first one, of course, very important, is the healthcare directive. So on the healthcare directive, this one lists who can act as proxy for the patient. It lists members as proxy 1, proxy 2. So big thing you want to keep in mind in Manitoba, proxy is the term used for someone that can make those medical decisions, whereas commonly a lot of people talk about power of attorney, and Manitoba power of attorney is more so for financial matters. So if you have someone there that's a proxy, someone that's there as power of attorney, we want to talk to the proxy because they're the ones that can make these medical decisions for our patients. And they'll have their name. So if proxy 1's not there, we'd obviously go with proxy 2. If proxy 2 is there and proxy 1, we'll talk about how to deal with that issue. Because on here, if you look at the bottom, it says if there's more than one proxy there, so do they have to make their decisions unilaterally or jointly? So sorry, consecutively or jointly. So if it's consecutively, that means proxy 1 has authority over proxy 2. So if the daughter is proxy 1 and the son is proxy 2, the daughter would have the primary say. So if she's saying go to the hospital, proxy 2 is saying no, we'd have to listen to proxy 1. That's obviously going to be a very difficult situation to be in, but we're going to try and, again, use soft skills, have the conversation of, are we making the right choice? Is this what's best for the patient? And we always want to make sure that they're aware of, because people panic at end of life. They know this is coming. They know what's happening. They might have been with this person for quite some time. And we might want to help guide their decision to, is this what your parent would want at end of life? Would they want to be taken to the hospital? It's 2 hours away where you can't visit, or would they want to stay home? Because some people don't always make the best decisions in our mind, or what the patient may want at end of their life. So try to have the conversation with them first about what would be best for the patient. But at the end of the day, proxy 1 would have the say on what happens with the patient. If it says jointly, that means proxy 1 and proxy 2 have to have an agreement. So if one's saying stay, one's saying go, we're going to have to kind of be a bit of a mediator and help them make that decision. On the bottom there, it talks about no restrictions. So at the bottom, it talks about, it talks about making decisions with restrictions as follows. So with no restrictions means that they have full reign to make whatever decisions they want to make. If they want to transport, then so be it. If they want to stay home no matter what, that's their choice. But if it says with restrictions as follows, so with that, it may say do not transport under any reasons, do not resuscitate under any reasons. So with that, that means the proxies could not override that request. So if proxy 1 wants to go, proxy 2 doesn't want to go, and they're having disagreement, we can say with restrictions as follows. So it says no transport there. So we can use this as a reference document for that. So for treatment instructions on the other side of the page here, it may be left blank or state do not resuscitate, comfort care only. A lot of the ones I've seen personally, they're usually blank, but there are some that have very specific descriptions of what they would like done, what they wouldn't like done on the sheet here. In part 3, they have signature and date. So if treatment instructions state do not resuscitate and it's signed here by the patient, then you can use this as a DNR. If you're unsure whether it's valid or not, discuss with the proxies. The caregivers are on scene. If like, yeah, he doesn't want a DNR, here his healthcare directive states he wrote out straight up DNR, signed it, then we can use it as a DNR. Again, talk to them. If you're still unsure, you can always contact online medical support. We have advanced care planning goals of care. So when again, if we ask if there's an existing healthcare directive, if yes, refer to healthcare directive documentation. And again, this should all be with the patient's folder in the home. So the goals of care document here as a list. So a patient ideally should check off one of these boxes. So the first one we have is C for comfort care. So this would be the goals of care and interventions are directed to maximal comfort, symptom control, and maintenance of quality of life, excluding attempted resuscitation. So again, this is where a care map comes in very nicely because it talks about symptom control and comfort. So that could mean that even though they have very slow respirations, but they seem like they're in a lot of pain, we can still give them opiates to make them comfortable because that's comfort care. For the M for medical care, goals of care and interventions are for care and control of the patient condition. The consensus that the patient may benefit from is accepting of any appropriate investigations, interventions that can be offered, excluding attempted resuscitation. So with that, with medical care, so your palliative care patient, they have developed pneumonia, but they have cancer. They're totally two different things. You can still take these patients in to get their pneumonia treated. It's something very different from what their palliative condition is from. So one thing that came up with this as well with medical care that had to be kind of looked into is we're not supposed to resuscitate, but what if they're having trouble breathing? So with this is we can give assisted ventilations because that's not resuscitation, that's assisting ventilations. But once they stop breathing, we would probably not be tubing these patients. We would still, but we can assist ventilation, it's just not full CPR. So if they check off R, so that's full resuscitation. So the goals of care and interventions are for care and control of the patient. The consensus is that the patient may benefit from and is accepting of any appropriate investigations or interventions that can be offered, including attempted resuscitation. So they're a full resus, basically. This may change over time. And again, if the proxies have changed their minds, so let's say that they haven't updated this since like 6 months ago when they first started this process. And now they've got documents saying, yeah, he's got a DNR now, you can disregard that. That DNR would overwrite this because technically this document is not a DNR to start with. This is just the goals of care. So something to think about there. On the other side of the document, the top half of the page lists the names of the members involved in the decision process. If the patient's name is printed, but the patient did not sign, then technically you can't use this as a DNR. Below there's a list of names and there is a section for specific instructions on wishes or details of discussion with the individuals listed above. So again, they may write in the narrative here that they want to not be resuscitated. They might write DNR, and if they write that and they sign it on this document, the patient has to sign it. As long as they sign it, then this can be used as a DNR as well. So if they check off do not resuscitate on the front, they write their name out, they sign it, they write in the narrative there, do not resuscitate, then you can use this as a DNR. If there's family members on scene, they may 100% comply with that. They may have a discussion, but again, that's might have to happen. It may not, but always talk about goals of care with the family. So the notice of anticipated death letter, again, this should be in their home care file as well. This is sent out to like the RCMP, things like that. So when the patient dies at home, it's not unexpected. It's not a suspicious death. They knew it was going to happen. They know the disease trajectory of the patient. So with this, it'll be set up with the palliative care. It should be in their palliative care folder in their home as well. So technically this form is not a DNR, but if you do have a patient that is registered in the palliative care program with this letter, that means they're expected to die and very soon. So if you arrive on scene and the patient is already deceased, they have a notice of anticipated death in their folder. And the family's like, yeah, they've had this terminal disease. We were told they had a couple days to live and now they're dead. You can treat that as you do not need to attempt resuscitation because this notice of anticipated death has to be signed by a physician. It's already been sent to the RCMP, so this death isn't going to be suspicious. They don't need to come investigate it. You don't need to start resuscitation if they already have this. Because again, if they're registered in palliative care, they have this, they died due to their disease process. That's just the process, right? People die. We're not going to attempt resuscitating these patients. If the patient is deceased from something other than their palliative care conditions. So let's say they were driving home and they crashed their car. This doesn't really hold any, this document here, if they have a DNR, obviously we do not resuscitate, but with this document here, that wouldn't override resuscitation, unfortunately, because it didn't have anything to do with their palliative care condition. Okay. So one thing to keep in mind is that if we get called, sometimes for these, for notice anticipated death, again, it's not a big illusion to the family that their loved one's going to die and they're at end of life care. They may call us just to say, can you just like confirm that they've died? So we can do that, but we also don't just go, yeah, they're dead and then leave. There's also that emotional support that the family may need from us as well. And sometimes that's just why we get called, is that this person's obviously dead. They knew it was going to happen, but when it happens, it's a big shock to the family. So they may call us just for that. They don't know what to do. So they just feel like they need to call someone. So they call us. So we can still provide emotional support for the family and caregivers. It's even though we're not going to attempt resuscitation for the patient. So that's reviewing goals of care with the patient and caregivers. The next thing on the first box, the care map here, is to assist with administration of previously prescribed medications. So one of the big things when we created this care map was we discussed, like, if your patients that are registered within the palliative care program will be assisted through the IRHA pharmacies. So their medications will be pre-drawn, they'll be in syringes, they'll have their documentation once this is all set up properly. They should have their documentation stating how much of a med and when they should get it. So we might get called for a patient that, let's say he's got a new subcut line, the family is not comfortable using it, they saw it once, they're not like 100% sure, so they might call us to help with medication administration. We didn't really see the point of us driving a patient an hour and a half to the closest hospital to get a 30-second injection and then drive them back. So we made it so that you can give a medication to a patient if it is prescribed to them. You have their documentation with the note from the physician of the dosing, date, time, all that stuff there. And if we're giving it as prescribed, it doesn't matter what the medication is, if you're familiar with it or not, you can administer that medication. And again, this is just another step we added in to help keep these patients at home, because that's pretty ultimately the goal for the care for these patients. So the other thing as well, again, like I always say, if you're ever not sure about a medication, you can either contact a palliative care nurse. So if it's during the day, palliative care nurses may be available. So try to get the number for the palliative care nurse. You can give them a call and just confirm, yeah, this is all good. Or always, you can call online medical support if you have any questions about a medication. One thing to keep in mind, like I said before, when you're giving these medications, we don't necessarily need to do vital signs, because if it's a standard medication, and it may not negate us being able to give a med just because the patient's hypotensive or something like that. So when we look at our care map here, so we want to talk our goals of care, and we can assist with any medications, because it may just be as simple as we start a subcut line because theirs fell out and we give a med and we're done. But if that's not as cut and dry as that, we want to see, is our patient in a crisis situation? So we want to look at, is there an impending airway obstruction? Are they bleeding out? Or are they having seizures? So if the answer to this crisis situation is yes, we can use midazolam or ketamine. So for impending airway obstruction, is it positional? Obviously, if they're choking and they want care, we can get rid of the choking, right? So we can deal with that. But there's also things as well. So if they are, we want to look at positioning of the patient. We can do suctioning, absolutely. And we can try to make the patient more comfortable. So with that, we could look at midazolam for making the patient more comfortable, may restrict stress and tension on the patient, and make it easier for them to breathe. Other things we have here as well is for ketamine. It can be used to reduce pain, discomfort, and ease suffering. So again, if depending on what's going on with their palliative care situation, it may be throat cancer or something like that, and we're not going to do anything about that obstruction. So all we can do is make them comfortable. So again, we can talk to the family what they would like. We can look at using midazolam, or we can look at using ketamine. And again, ketamine is a newer med that's been added to the care map. So this is a bit of an update here because we have it in our toolbox now. So we want to make sure that we're able to use it for our patient and reduce suffering and end of life. So for massive hemorrhage, this one's a kind of a tough one because if they've got like really bad esophageal varices and they're starting to cough up a lot of blood, things like that, it's going to be traumatic for the family. So as we discussed in the palliative care training, the family is going to be educated to have like dark towels, linens available, things like that, so we can assist them with that. Because we're not going to stop this bleeding. We're not going to fix this patient, but we can make it less traumatic for the family. So by having those dark towels, blankets, we can help reduce the sight of the blood of it soaking into like white sheets so it doesn't look so bad. Also, like if they've got a lot of blood in their airways, suction it, right? We don't have to watch them drown in blood. That's pretty harsh. So we can use our suctioning to clear large amounts of emesis, blood from the airway, and clear the obstruction or clear the blood on scene. And again, they'll have direction, look at their care plan. They may have midazolam already set up for these patients. We can use their midazolam or we can use ours. And again, just to ease these patients so they're not suffering at the end of life. If patient's seizing, we treat that as a seizure, right? So if they're actively seizing, our normal go-to is midazolam for stop seizures. So what we would do is we do like we normally do. They have a seizure, we give midazolam, we try to stop the seizure. And then once the seizure stops, we need to make a decision on what's happening because have they stopped breathing? Are they deceased now? Or are they starting to come around? Do we want to transport? Do we want to stay home? So that might be a conversation we have to have with the family or caregivers. So in the care map, we have embedded the actual medication dosages here. So as it says here, midazolam, so for PCPs and up, you can give it any route as required. And again, for here, we don't necessarily have to do vital signs pre-imposed if the family wants us to, absolutely. But again, if they're very cachexic, so they've got that muscle wasting, using a blood pressure cuff on them may cause a lot of damage to them, like a lot of bruising, just because they don't have that muscle mass anymore. So we want to make sure that we're doing right by our patient. So we may not always want to do a full set of vitals. As you can see here for Midaz, it doesn't have IM. It says intranasal, subcutaneous, intravenous. And again, because these patients, if they're cachexic, they may just not have muscle mass. So IM may not be the best option. So you do have intranasal, subcutaneous IV. And again, that's based on what you think would be most effective for your patient. If they're actually seizing, intranasal will probably be your go-to because it'll act faster. But if they continue to seize and it's distressing the family and the patient, then we could look at starting an IV so we get multiple dosages of midazolam. So for ketamine here, for PCP, we can only give an intranasal. For ICP, you can give it subcutaneously, intravenously, or intranasally. So you got basically all your choices there. And it's got your dosing. And these are all in the care map, so you don't have to be referencing your medication profiles. So with crisis situation, if the answer is no, we want to look at and see if they have any pain. So again, this is going to be referenced to our patients. So we kind of need to figure out what their baseline is because these patients may be living with pain all the time. So you might say, what's your pain today? And they're like, oh, it's a 6 out of 10. And you say, what's your pain normally? And they're like, it's a 3 or a 4. Usually it's kind of managed, but it's constant. So just to get an idea of where they're at, because if we just say, do you have pain? Then they might just say, yes, that's just my life now. I'm in pain all the time. So we want to ask them is, what's going on with your pain today? So if the patient is suffering from pain or is not having effective pain management with their current prescribed medications, so again, as their disease process continues to develop, oral medications may not be working effectively for them, their dosing may not be working effectively for them, or they might have run out of pain meds because they're using so many breakthroughs because their pain meds are not being effective for them. So we may have to look at using our own medications here. Always do your own assessment though first, because is it a matter of the pills aren't working? Maybe they're just very nauseous and they're vomiting up their pain meds. So we can give them antiemetic and then they can take their pain meds instead of us just doping them up on morphine. It's a conversation to have, like I said. We want to use our OPQRST because, again, is this a new pain? Is it a different pain? Is it relative to what their palliative condition is, or is this a new pain? So it could be that they're developing bed sores, which is not necessarily something to do with their palliative care. What their disease process that's put them in a palliative condition. It could be that they need more effective bedding or more stable environment to help reduce those bed sores and that pain from being in this bed. And that's something that we followed up with their palliative care worker. The other thing as well, again, the OPQRST, we also have U and V, so the understanding of what's going on with your pain. So the patient's like, yeah, it's the same pain I've always had. It just, the meds aren't working anymore. Or is this new? I'm probably dying, or they think it's just something else is going on. So talk to the patient about what they think's going on. And for values for V, like what are they hoping we can help them with? We're not going to fix their pain. That's their life now, fortunate to say. So we could ask them, what do you want us to do? Just want to help you make it more comfortable? Do you want us to be able to contact someone for you to see if you can get more meds, things like that? So ask them what they would like us to do about their pain. So the big thing as well is that if their pain is really severe, we may not be able to treat it with what we have. So for for any of these situations, transport's never off the table unless their documentation says under no conditions whatsoever. But if the patient's 100% with it and they can make their own decisions, if they decide they change their mind, they want to go to the hospital for pain control or anything else, then yeah, we can still transport. It's never off the table. It's just not the first go-to, is just load and go. Other things we need to consider when we're looking at pain is we want to see if there's that belt-like pain, because again, if they have mets of the spine, things like that, we could be worried about spinal cord compression, and that needs treatment. You have to transport for that. So they're going to need therapeutic radiation for that. And recognizing that is really important, because obviously we can't deal with that at home. They're going to need transport, and then there's going to be a decision have to be made by either the patient or their proxies. So when it comes to actual giving pain control, if you look at the care map here, it talks about fentanyl for PCPs, all routes. So for the use in this care map, PCPs are permitted to give fentanyl intranasal, subcutaneous, or IV. Okay. So that is available for PCPs just on this care map right now. Morphine is still ICP, that hasn't changed. And ketamine, of course, is an option, and like we discussed before, for pain control. So when it comes to giving fentanyl, like I said before, PCP, it is now, you can give it intranasal, subcutaneous, or intravenous for palliative care patients. With the new updates in regards to giving fentanyl, stating you have to have an IV line in place before giving intranasal fentanyl, that is not a requirement for the palliative care patients. Again, because end-of-life care, the reason we're giving intranasal might be that they can't get an IV. So you don't need to do that for these patients here. So for morphine, it has all the dosaging here in your care map. So when we're giving morphine, we can either give it as a new medication, or we can give a dose equivalent comparative to whatever medication they're currently taking. One big thing I want to bring up is that if you are giving morphine to your patient, a lot of times when we give this IV, you should be diluting it. If we're going to give morphine through a subcut line, please do not dilute your morphine, just give it straight. You can only give 2 mLs of medication at a time through a subcut line, because you need a 0.5 flush to clear the line. You can give your 2 mLs of meds and then a 0.5 flush, so max 3 mLs through your subcut line. So a more concentrated dose of the med will be able to give more meds. So with that, like if you're going to give it IV, dilute it as per the norm. But again, subcut lines, don't dilute your morphine, just give it straight up, because that gives us a chance to give more pain control as well, because we can give more concentrated medication dose. So when it comes to giving morphine, we have to look at what they're currently taking. So there's the conversion chart in the care map here. We made little laminated sheets of these that should be in your med bags as well, or in your IV bags, depending on where you keep them in your truck. It tells you how to convert the dose based on what they're taking. So with this here, so for example, if your patient's taking 4 milligrams Dilaudid, which is hydromorphone, for breakthrough pain, and we only use the breakthrough pain when we were doing this medication, so not their long-term acting medications, just their breakthrough meds. We want to do some math here. So let's say they're taking 4 milligrams of hydromorphone. We carry morphine. So we would take their hydromorphone dose and we would times it by 2.5. So because we're going to give it, let's say we're going to give it through their subcut line, we can give the conversion would be 4 milligrams times 2.5, which would equal 10 milligrams of morphine, which non-diluted would be 1 ml. So we can totally give that through a subcut line. So we would take that and we would give it either sub-Q or IV based on how quickly you want it to take effect. So again, when it comes to routes, we may not always want to do an IV, but if we think it's going to be beneficial for our patient because they're in a lot of pain and distress, that we start that IV and give the first dose IV and then look at follow-up dosing through a subcut line, we can look at that as well. Because again, subcut's not going to take, it's going to take a lot longer than IV. So if patient has had no pain control for quite some time, you might want to look at an IV as an option. Another thing to look at here is that if they're taking oral medications, again, that might be a change in their condition where they can't swallow pills, their digestive tract isn't working effectively anymore because they're not eating or really drinking a lot, so they're not getting that pain control through their oral medications. We may have to give it subcutaneously or intravenously. So if we look at our patient, they're taking 5 milligrams of morphine orally for breakthrough pain, and it's not working for them for the reasons I already listed. What we do is we take a conversion chart and it says oral dose of morphine, and then we times it by 0.5. So we would give them, it's 5 milligrams times 0.5, so we'd be giving them 2.5 milligrams of morphine, either intravenously or subcutaneously. And again, not diluting it through the subcut line. When it comes to starting subcut lines, if we start a subcut line on scene, so we can give this medication, or the patient had a subcut line, it's not effective anymore, we discontinue theirs, we start our own. Or if they have one on scene, we can, we want to make sure it's patent, make sure it's not infected, make sure you flush it first. We can use their subcut line as well. But if we start a subcut line when we're on scene, we have the option of leaving it in place. So if it's just easier for us to give it through the subcut line and the family's like, yeah, you know what, we're probably going to switch that anyways, can you just leave it in? We can leave that in for multiple days. Just ensure that you document in their home care chart that you started the subcut line and when you started it. That way they know if it needs to be removed or replaced after a certain amount of time. If you start an IV to give pain control, though, that's got to come out before you leave. We can't leave that in place in the patient. This just causes risk for infection and possible uncontrolled bleeding, especially if they accidentally rip out their IV line. So subcut lines you can leave in based on what you think and what the family thinks or the proxy thinks is best for the patient. IV lines you need to take out. So that's pain control. Let's say they have no pain right now. There's no pain of any severity. You've got them all morphined up. They're doing pretty good. But are they having dyspnea or respiratory distress? So we may look at giving supplemental O2 because again, if they're just short of breath, they're having some kind of like panic attack, like we would for any other patient, we can give them some O2 if that'll help them with their breathing issues. Other things we look at for this, again, before we go to medications, is we can just look at straight up patient positioning. Are they all crouched down in their bed and they're having trouble breathing because they're in an awkward spot? It might just be as simple as repositioning the patient, making sure they're comfortable, they're in a better, maybe just helping the family roll the patient on their side because laying on their back may not be working for them anymore. And other things as well is that if they're in respiratory distress, we still want to do assessment again, because just because they're palliative doesn't mean they don't get full care. So auscultate the lungs, check for temperature, maybe they're febrile, maybe they've got pneumonia, or maybe they're having a severe bronchospasm due to something else not palliative related, which we could then treat with something like salbutamol, or they may need to go to the hospital for antibiotics, which again would be a conversation with the patient and their caregivers. So we still want to do a full respiratory assessment on these patients. Other things as well that we discussed in palliative care class could be just that putting that fan at the end of the bed just to help with the airflow, get rid of that shortness of breath the patient may be having. Some of those non-pharmaceutical interventions may be very beneficial for the patient. So it talks about fentanyl and morphine. So these medications normally, for years, we're always telling people don't give people too much morphine, it'll stop their breathing. We're going to be giving these patients opiates or opioids just to help reduce stress and suffering of patient and just kind of relax them and make it easier for them to breathe. But again, if that's part of their disease process where this is just the natural progression of their disease versus they now have an asthma attack, we're not going to give these patients fentanyl morphine. We'd go with more traditional salbutamol. So again, this is why it's important you still do a respiratory assessment on these patients. So if they are not having any dyspnea or respiratory distress, are they having nausea, vomiting? So with that, if the patient is suffering from nausea, vomiting, and we want to do an assessment of why are they having this really bad nausea, vomiting now? Is this new? Is it been going on for a while and they're just tired of watching someone vomit all the time? We want to do a bit of investigation, so we can ask about, like, is it medication, which again could lead to pain control. So if we show up and the patient's taking oral meds and they haven't had any oral medication for pain control because they're throwing up all the time, we can look at, okay, let's get the vomiting under control. We can give them some pain control, and we can take a look at what's going on with our patient here. So it may not just be one issue you're dealing with at a time. So if they're having medication issues, as in they got a new medication that's causing this distress, this gastric distress, that's something that you can hopefully maybe try to contact the palliative care nurse, or at least say that we need some follow-up care for this patient to deal with this issue. We might have a recent change in therapy. So some patients that have terminal cancer, they still get radiation therapy just to help reduce pain. So that can be very hard on the body as well. So if that's where they're vomiting. If their food intake has decreased, or they just get the smell of food and they're nauseous all the time because of that, we may look at, we need to move the patient. We may have to tell the family, stop trying to feed them. It's just their disease process. They just don't want to eat anymore. Stop trying to force food on them, kind of thing. Or it's just not good to keep trying to get them to eat. So again, conversations to have with the family. Another big one as well is that if the patients are taking opioids, they can cause constipation. So if they're not having their constipation under control, so they're not having stool softeners, laxatives, things like that, they could be really constipated, and that's not an uncommon issue for these patients. So obviously, if their bowels are completely full, that's not going to be comfortable. It can cause nausea, it can cause vomiting and gastric distress. So it may not just be something as simple as, here's your antiemetic, have a good day. We want to make sure that we're doing a full assessment of what's going on with their patient. Because again, if they haven't had a bowel movement for like a couple days and we're suspecting maybe possible bowel obstruction, they're going to need transport for that. So we need to have a conversation with the family. So again, do a full assessment, your OPQRST in regards to nausea, vomiting, and then if we do that, we can decide where we're going to go with our therapy. So for medications, we have Maxaran and ondansetron. So again, these dosages are put in the care map as well. So when I talked about if they have a suspected bowel obstruction, we might want to give an antiemetic just to make them more comfortable, because that actually can affect their breathing too. Because you got to think, if their bowels are full, it's going to put pressure on their diaphragm. So there could be a lot of things caused by this constipation: pain, discomfort, nausea, vomiting, shortness of breath. So it might just be that they need to go to the hospital and get that bowel obstruction or that constipation dealt with. We're not doing manual decompaction, so they would have to have that done at the hospital. So again, conversation to have. They may have multiple symptoms that we're looking at. So if we are suspecting a bowel obstruction, though, we don't want to give Maxaran. It is a good antiemetic. It doesn't cause as much sedation as Gravol does, but because this one actually works on the brain itself. The other thing as well is that if you're thinking there is constipated, not quite a bowel obstruction, and a bowel obstruction, the biggest way to tell is that if they're just not passing gas anymore, that's a good indicator for bowel obstruction. But if their bowel is very obviously distended and you're like, it could be, I'm not sure, maybe stay away from Maxaran, because Maxaran itself, it works on the brain to stop your nausea, vomiting, but it also increases gastric motility. So if they have an actual bowel obstruction and your bowels are actively trying to use that peristalsis to get the feces out, and it's not going anywhere, it can actually cause damage. So it may not be the best option for your patient if you're worried about that. The other medication we have here is ondansetron. So this has been shown to be a very effective antiemetic for palliative care patients, especially the ones that are going through radiation therapy. This is kind of the go-to for that. So like I said, if they're just going through radiation therapy for pain control, just to try and reduce the amount of development of their cancers, of their tumors, ondansetron would be a better option for these patients. So one thing I'd like to bring up, though, with this, as you can tell here, it says for PCP, you can give subcutaneous or intravenous. So normally for all other patients under our care, ondansetron is an ICP scope medication. For the palliative care at home, as a PCP, you can give this medication. So again, it's a very effective medication. We didn't want to deny it for our patients if it works well. So for this, just for palliative care patients, PCPs are permitted to give ondansetron. So nausea, vomiting. So we looked at that, we dealt with it. If the answer is no, we're all good. Then we want to see, is there any airway secretions? So at the end of life, patient may have fluid in the airway that's not being cleared just because their LOC is so decreased. They're not in any distress. It's just they're at that end stage of their disease progression. And so just sometimes secretions can get stuck on the vocal cords and it can cause a very unpleasant sound. They used to call it the death rattle. Don't say that to the patients. This sound can be heard and it's very distressing. So there's nothing where you can really fix with suctioning. Obviously, if it's higher up in the mouth, like if they're drooling excessively, then we can suction that. But we talk about that death rattle sound, that's at the vocal cords, and that's just patient losing their ability to swallow and secretions are just collecting. And there's not really much we can do about that. A couple things we can do non-pharmacologically is we can put them on their side, allow for drainage. If that's okay with the family, they can help us. We can just reposition, and that might help get rid of that sound. We also, if that doesn't work, we can also put on the scopolamine patch. So it's just the transdermal patch. It's just placed right behind the ear around about here. And that can help dry up secretions that can lead to that death rattle sound. So one thing is those scopolamine is just straight up not being made anymore. The manufacturer is no longer making scopolamine. So we did decide to leave it in the care mat because even though we don't have a continuing supply, we still have a lot of them left in our stores, both on our ambulances, our stations, and some at the pharmacy. So we left it in the care mat because we're just going to keep using it until we run out. And then we'll look at maybe some other options later on down the road. So with scopolamine, again, that's just used to drive secretions. Sometimes it's just used more so as a psychological support for the caregivers, family members on scene that we're doing something about it. And that could just be we're putting this patch on for this medication, and hopefully it will help get rid of that and it'll ease that noise. And hopefully that'll be enough to put people at ease that something is working. In all honesty, it's going to take a while for that transdermal patch to start working to reduce those secretions. And a lot of times, just from talking with people that have experienced this, usually your patient's deceased before the scopolamine actually kicks in. So a lot of this could just be more so for comfort of the family members to see that we're doing something about that, that sound that is very unpleasant from that patient. So if there's no airway secretions, then that's not a concern we have. Is there anxiety or agitation? So there we go. So if there is anxiety or agitation, we can use midazolam. But again, before we start giving medicine to people, there are non-pharmaceutical ways to deal with this. So we can look at the environment of the patient. So is the patient just being very overstimulated? Is it like a lot of houses we go to where they have the TV on full blast, just that constant noise? There's lots of activity, bright lights. It might just be overstimulating for the patient. It's just too much. So we may want to look at maybe like darkening the room, turning off any loud noises, things like that, giving the patients hearing aids in their glasses so we can communicate them more effectively so they get less irritated. Because if they're constantly just having people yelling at them, that can be very irritating for the patients when simple as just put in their hearing aids and then we can have a straight conversation with them. It may help reduce anxiety or agitation. On the flip side of that, it could not be the patient that's the issue. It could be that the caregivers. So if the caregivers are just straight up burnt out, they could be very anxious themselves and just be very done and just like overreact to a lot of things that are going on with their loved one. So we need to have a talk with the family about what they need. Maybe they need a respite. I've had a couple of these calls where people just call us saying, you just need to take them out of here. I can't take it anymore. They're just always falling down. I can't keep doing it. I haven't slept in a week because they keep having issues in the middle of the night. So again, it may not be that the patient is acting out of sorts for them. It could just be that the caregiver can't handle that level of care anymore. So there's just a failure to cope on the caregiver's side, which is very difficult for a lot of these caregivers to admit. And especially when they need to send them off with us, it's not an easy thing for them to do. Other things we want to look at as well for anxiety or agitation, if they've had a head injury. So if they had a fall last night and they're starting to act strange now, is that due to a head injury from a fall, or is this just a natural part of the disease progression? Have they had any incorrect medication administration or any change in their medications? Because that could be causing a difference in their LOC and the way they're behaving. Big thing as well is to determine if it's dementia or delirium. Because again, if they've just started a new kind of med and now they're starting to act very out of sort, they're very agitated, anxious a lot, things like that, that could be more of a delirium, like a rapid onset of this altered LOC versus dementia, which is just long-term. So we want to decide, is this a new thing or has this been ongoing for quite some time? Because again, if it's been going on for quite a while, where the family's constantly having a battle to keep grandma in bed so she doesn't keep falling down the stairs, that can be very tiring on everybody involved. So we can ask, what's going on, what's different today, how are they normally, what's their baseline to determine if it's new onset versus something longer term like dementia. So if we're worried about if they're taking opiates, so with opiates, like I said before, we're always worried about constipation. We are worried about metabolites from the morphine as well, or from the opiates. So we could look at giving some fluid therapy to help reduce that. If the patient's with it, they can just drink lots of water and just tell the family, you know what, they're on a lot of opiates right now, so they need that fluid to help get rid of those toxins. So just lots of water for the patient. If they're not really able to get them to drink a lot, maybe we could look at doing some IV therapy. So just maybe give them some fluid, and saline would be fine, just to help flush things out their kidneys. And then the family can transfer over to oral fluids after we leave. So with this as well, there's always the concern of personal injury or safety, both for yourself, the caregivers, and the patient, because obviously if a patient's combative, a patient's combative. So if there is ongoing concern for safety for everybody involved, both for the patient and the caregivers, then we may have to look at transporting, because obviously if it's a highly combative patient, I've had a couple patients. Actually, the only time I've ever had a patient successfully punch me was this very nice little old lady. She was like 80, and she was just sitting there quiet, and all of a sudden just turned around and clocked me, just out of nowhere. And that they're like, "Yep, that's about right for her." So obviously, the family is constantly worried that they're going to get hit. So that could cause caregiver burnout. So maybe that patient needs to be somewhere more effective where they can be monitored. So we may have to have a conversation of transport. And again, if they are being overly combative, if they're at risk of endangering themselves or others, then we can use midazolam, like with any other agitated patient, to help sedate the patient to prevent any further damage to themselves or us. So if that's not an issue, if everything's going well, if the goals of care do not include transport, we support them on scene until issues resolved. So a big thing we push when we were doing the in-class sessions on these is that we may have longer on-scene times, because we may want to wait to see if the pain control works. We may want to see if the antiemetics work. We may have to deal with that agitated patient. It may take us a little while to calm them down enough, or get them, a little bit more emotionally stable, and then start fluid therapy, and that takes time. So again, conversations with the caregivers. And if they don't want to be transported, we can't force them. But if we think the patient should be transported because, let's say, it's a condition that we believe is not part of their palliative issue, we may want to transport them. So that's a conversation to have with the caregivers. If a patient is not to be transported, we do not need a signature from them for a refusal. All we need to do is document effectively on our PCR why we were there, what we did, what care was given, and the outcome. With these patients here, we're always going in with the assumption that this patient is on the palliative care program because they want to die at home. And we're going to help them reach that goal because that's more comfortable and that's what the patient wants. So if we end up doing therapy, so let's say we do a whole bunch of stuff. We start subcut lines, we give opiates, we give antiemetics, we do emotional counseling, reposition, things like that. We want to document all that, but we do, and then they're like, okay, well, see ya. We don't need to sign a refusal. All we need to do is on the front, we would sign a treat and release with this one here. Because again, they're not refusing. The plan was, in their care plan was never to come with us in the first place. So they're not refusing transport. It was never an option for them. Okay, so we do not need an actual signature for these patients, as long as they're registered within the palliative care program. If they're not registered in the palliative care program, that's a different topic. Then we treat it like a normal call. But with this as well, if you're going to do it as a treat and release, and please make sure you put the patient's SPP number on the top of the front of your PCR. So that way, one, it helps us with data collection for this program, because again, this is still a trial. This isn't permanent. So we want to make sure we keep it. So with that, we need to have numbers to help back up what we're doing. So make sure you put that SPP number in the front of your PCR. And when you put your treatment release, so we know, okay, yep, they're registered with the palliative care program within the region, did a treatment release, it's all good. And if you're not transporting, fill out your PCR in the home, make sure you document everything, and then leave the hospital copy of your PCR in with the progress notes in the patient's home care folder. Also with that as well, inside the home care folder, there will be integrated progress notes. So make sure to write in there, EMS crew, Northeast 0101 was on scene at this time to provide patient care, left at this time, PCR, just document what happened, what you're doing, why you were there. If you are to transport the patient, make sure you write down in those progress notes that, Northeast 0101 transported patient from address to Beausejour Hospital at this time. And just that way, if home care shows up and they're like, where's my patient? They can look through the notes and say, hey, okay, they got transported by EMS at this time and date. And leave your names and your license numbers. That way we know which crew took the patient. So if we need to reference back when they were taken, we can figure that out. It is extremely important that if you transport these patients, you do not take the home chart with you to the hospital. Do not take their palliative care documentation. We've had a couple issues now where that's been taken more early in the project when we were figuring stuff out here. But if you take that home care chart, and I'm sure everybody's had patients, because I know I've had my fair share where you take their ERG package with them and then they never see it again because it just disappears when they get to the ER. So that chart's super important. Do not take it with you. Leave it at home. You cannot risk losing it because, again, it's got all our medication orders, all that stuff in those folders. If you are going to transport the patient, again, just make notes in your progress notes in the chart. Do not leave your PCR there. Take it with you, and you would hand it into the hospital as you would for a normal call. One thing that's been brought up by quality assurance here is that we need to do data collection for how it's going for this program. So on the back of our PCRs, I'm sure everybody's seen this. It says condition at destination, unchanged, improved, deteriorated. We need to fill these out. Yes, we're not transporting these patients. They have not left. So, but we need to have documentation of whether the patient got better, they didn't change, or they deteriorated. So with this here, so if they improve, so let's say we showed up for patient for pain control because their oral meds weren't working anymore. So IV morphine, that got rid of their pain control. They're like, great, grandpa's doing great, you can leave now. Then make sure to check off improved. This is very important for our data collection to help support our palliative care program here. Once you get back to station, I get everybody's really busy and it may not be the easiest thing to do. Not everybody's familiar with how to use fax machines. We're trying to work around that to figure out a better way to get PCRs to the palliative care team. But if you know how to work your fax machine and your PCR doesn't get jammed in it while you're trying to fax it, can you please fax a copy of your PCR to palliative care team? This is really important because they need this information to keep track of as well. Because like I said, there's not a lot of nurses and we have a lot of patients and a lot of geography for this region for them to look after. So making sure that you send a copy of your PCR to the palliative care team. This helps them keep track of their patients and what's going on with them. So again, if I think we had one patient, if I remember correctly, they had EMS visit them 3 or 4 times in a weekend for pain control. That's something the palliative care team needs to know because obviously whatever's going on with that patient is not working for them. So it's very important that they get that information so they know what's going on, and that could put that patient at higher priority to be visited by the care team instead of just their regular, we'll see them when we get around to them kind of thing based on their patient load. So at least try to do that. And that's all I have. Thank you very much. If there's any questions after watching this recording here, please feel free to email me if any questions, or you can give me a phone call to ask any questions in regards to palliative care. Thank you very much. Have a good day.